to the face now. We're going to start with orientation to the nose. So even though it says lacrimal bone, if you look at the nasal bone here, that's what forms the bridge of your nose. Okay? So where your sunglasses would rest, or your regular glasses are resting on that bone, it has no other processes that you have to identify. Okay? However, the nasal bones are not part of the socket that forms your eye. They're outside. When I have my fingers here, it's not inside my eye, pushing up against my eyeball. The next bone that you're going to touch as you slide your hand from your nose down the side of your nose, you're going to have a piece of your upper jaw, the maxillary bone. There's a narrow piece in there that fills that portion. So right here, that's maxillary. And now we're in the orbit. So the lacrimal bones are, if your fingernails aren't too long, and you kind of pinch right where the corner of your eye is, you're going to be touching the lacrimal bone. All right? The lacrimal apparatus includes your tear duct. Your tear ducts in the lacrimal gland is the gland that makes your tears. That's on the inside of the orbit, up here against the inside of this wall. So if we look at the orbit itself, the lacrimal gland is up in here. So the tears wash from the outside of your eyeball across the surface down to the medial corner. So at a diagonal, that gives a good wash. Because if it was down here, the upper part of your eyeball wouldn't get wet. And if it was here, the outer part of your eyeball wouldn't get wet. Okay, so this gives it a diagonal flow. And the only process that you need to know for the lacrimal gland is the opening in it, the lacrimal canal. So most of your skulls may be missing the medial ethmoid bone, but should have the lacrimal canal. Anybody having difficulty finding that? Okay, now this is a rather large opening. I've seen, those YouTube videos. William watches the crazy cat one. But little tiny baby corn snakes, people will thread them down their lacrimal canal and they'll come out their mouth. Normally that drains into the nose, but the back of the nose is open to your throat, and so it goes into that pharynx and then comes out through the mouth. All right, so we're almost ready to talk about all the bones of the orbit. You have a picture of that down at the bottom of your page. So if we look at, we've covered some of them. So here is this is the right eye. So the frontal bone is forming the roof of the orbit. All right. The sphenoid bone is forming the posterior wall of the orbit. The ethmoid bone and the lacrimal bones together form the medial wall. All right? And now we still have the floor and the lateral wall to find. So let's look at the upper jaw. It looks complicated, but we're really comfortable with it. We deal with it every day. So the processes should be pretty familiar. So if we look at the maxilla, you can either call it maxillary bone or maxilla, all right? It has this thin, narrow portion between the nasal bone and the lacrimal bone. So this would be part of the maxilla. And then as it curves around to meet the zygomatic bone, it's going to form part of the floor of the orbit. So right here, forming the floor of the orbit. Then it comes down and we have alveolar processes, the sockets for the teeth. And in this space here, if I'm drawing it as a dotted line, we have the largest of our sinuses, the maxillary sinus. Remember, all the sinuses except the mastoid sinus drain into the nasal cavity. The problem with this sinus is like trying to drain the bathtub through a hole in the roof. Because the opening for the sinus is up here, and it has to fill up before it never really empties. If you have a sinus infection, and that's the one that feels really pressure here under your eyes, especially if you bend over, and it hurts. It's usually due to a sinus infection. Okay, so that's the maxillary sinus, and some of you have that broken open, but you can see it on our exploded skulls up here and on the half skulls. Now, if you turn your skulls over and look at the roof of the mouth, the orange structure here is still part of the maxilla. If you take the tip of your tongue and touch it to the roof of your mouth, you're touching the maxilla. And that's known as the horizontal plate or palatine process. We have two bones that share the same name. And then we have two foramina. So those are the named processes. And we have two holes. One, since I have this image here, is right behind your cutting teeth or your incisors and is known as the incisive foramen or incisive fossa. Either term is acceptable. And that's where nerves from your teeth and the roof of your mouth go through. A dentist may use that to numb the front teeth. What was that one called? Incisive foramen or incisive fossa. And then if we go back and look at the front portion here, remember we have the infraorbital foramen or the second branch of the trigeminal nerve.
This is terminal.
Should be trigeminal. Sorry. Continuing with the formation of the hard palate, the roof of your mouth or the floor of the nasal cavity, about 25% to a third of that is formed by the palatine bone itself. And it also has a horizontal plate. And then finishing up with we have two more bones on the bones of the face. We've talked about the vomer already. Anybody have trouble finding the vomer? It's going to be a little shallow edge right here at the front and then bigger in the back. So if you turn the skull upside down, it's that narrow process between the two plates, the pterygoid sets of plates. And then the last bone of the face is the zygomatic bone. That's your cheekbone. Okay? So it's going to form your cheekbone. It's going to form the lateral wall of the orbit. And we'll go back and look at that picture in a moment. And then remember the arch across your face here? It has a temporal process. Remember, it's named for the bone that is extending towards. So this was called the zygomatic process of the temporal bone. Yep. And this short one is the temporal process of the zygomatic bone. Okay? So now let's look at the bones again that form the orbit of the eye. So think of it as a box. So just happen to have a box over here that I found this morning. So here's the orbit, the elongated eye. All right. So what bone forms the roof of the orbit? What would this bone be? Frontal bone. Okay. And the lateral wall, when we just talked about, cheekbone, zygomatic bone. Two bones forming the medial wall near the nose, lacrimal and ethmoid. And the posterior wall has the optic canal for the optic nerve, sphenoid. Okay? And then the floor would be the maxillary bone or maxilla, exactly right. Okay? So again, roof, frontal bone, lateral wall, zygomatic, medial wall, lacrimal and ethmoid, floor, maxillary, and posterior wall, sphenoid. But there's 7 bones that form the orbit, and I just named 6. So what we have forming the 7th bone is this tiny little piece of the palatine back here near the superior orbital fissure. Okay, so that's the 7th one. I wouldn't even be able to find it in your skull, but it's included in the bones of the orbit. All right, that brings us to the mandible. And this is the only movable bone of the skull, all right, unless you have a facial fracture. We don't normally wiggle our temporal bones. That's why the suture form immovable joints. So this one has 2 surfaces for joint formation, and all the rest are places for muscle attachment. So the most obvious joint formation is that portion of the temporal mandibular joint. So remember, in the temporal bone, we have the mandibular fossa, okay, and that is lined with an articulating surface of cartilage. The mandibular fossa is the joint surface of the temporal bone. And then the condyle, remember what other bone did we talk about on Tuesday that has a condyle? Occipital condyle, articulating with the first vertebra. So the mandible has a condyle that fits up in this area, in this region. The mandibular condyle. And it also has a surface of articular cartilage. Articular just means joint. And then it extends downward like this. And this area is known as the ramus. Ramus means arm. And some of your chewing muscles attached there. So if you put your hands here and close your jaw really tight, you can feel that muscle get fat, tight, and it's pulling on the ramus. Okay? This sharp point is another site. Remember the zygomatic arch? A muscle passes behind that, and it's going to attach here to pull the jaw closed as well. This is known as the coronoid process. So both of these are sites of muscle attachment. And this is a joint surface. And then the ramus extends, and this is known as the body. Muscle and the ankle. And if we have the 2 mandibles actually fused together, and at this point in the middle, we have a curve, a bend. So if we look at it from up underneath, these would be the 2 angles, and this would be the genu. Okay? So that chin area is the genu. Anybody know what genu means, as in genuflect? To bend. So she genuflected in front of the king. Okay, or did a little curtsy. So that bend in the mandible is the genu. And when we get to muscles, we have the genioglossus, the muscle that goes from the genu of the mandible to the tongue. So glossus is tongue, so we start connecting these structures.
Where is that?
It's this part right here. So let me find it. So this part right here. just where you have that bend of the mandible. So it's kind of be right here. Now, like the upper jaw, the lower jaw has alveolar processes for the teeth. And these are joint surfaces because the tooth is attached to that via a joint, a fibrous connective tissue. Yes?
Is that the alveolar margin?
The margin would be along the edge of that. The whole thing is the process. So the holes and everything, the margin is just the top edge of it, surface. But either term is fine. So I'm not going to draw cartilage in there because it's not a cartilaginous, it's not a synovial joint. All right. And then on the inner surface, as you can see right here, remember we have the mental foramen? And that's for the third branch of the trigeminal nerve. So on the sagittal cuts through the skull, they've opened up the mandible and the maxilla, and you can actually see the nerves coming from the teeth and going up through the foraminal valley. All right, and actually right through here, that's the facial nerve, going up through the foraminal valley. And so these come together, so the nerves of your skin, the nerves of your teeth, come together and come out this deep surface, the mandibular foramen. So if you look on the inside of your ramus, on this surface right here, you can see this opening here.
Is that not part of the tray?
It is. So the nerve that's going to go in here is going to join with these nerve roots, the nerve from there, and then come out, and from there go to the foraminal valley. Okay. So again, if you have dental work done on the lower jaw, your dentist will reach in against your jaw, press to find that bump in the bone, and then that's where the needle is directed for the local anesthetic to take effect on those nerves. And if he or she is a good dentist, they'll use the pressure of their finger so you feel the finger pressure and not the needle stick. Okay. All right, so now let's take a look at the temporal mandibular joint. And when we were talking about joints earlier, when we first started talking about sutures, we talked about 3 different types of joints based on their structure. A sutural joint, what kind of tissue knitted the sutural joints? Fibrous, okay? So those were fibrous joints. The teeth, by the way, are another example of a fibrous joint. So that we have the tooth in its socket, put a tooth in here, fibers, the periodontal ligament, if you know your tooth structure, hold that tooth in place, and that's a fibrous joint. Before we talk about temporal mandibular, we can just get that out of the way. So it's a fibrous joint. Would that be movable, immovable, or slightly movable? I'm not talking about when you get hit with a fist. Immovable. Okay? So our term for immovable is synarthrotic. Syn meaning with, in this case. There's another meaning in another case. The fancy word for this particular, like a sutural joint, classified the fibrous joint of sutures. All right? The word for this joint, specifically a tooth in its socket, is gomphosis. I love words that sound like what they mean. Can you just see somebody gumming their food when you say gomphosis? So if you didn't have any teeth and you had to gum your food. So, which brings me to this geriatric skull. Now look at the height of the body of that mandible compared to this one. The alveolar processes are all absent. This was an increase in the ratio of osteoclast activity to osteoblasts. The osteoclasts are removing bone faster than the osteoblast is laying it down And so we've lost the alveolar processes in both the maxilla and the mandible. Why would not having teeth allow that to happen? What's absent? You can't chew your food, and you have to eat applesauce and gum it. Are you putting much pressure on that bone tissue? Same reason why swimming is not a good exercise if you have osteoporosis. It's good for your heart, but it's not good for your bones. You have to have stress on the bones. You have to have weight-bearing exercises for maintaining the density of bone. Gumming your food doesn't allow weight-bearing exercises pushing on that bone tissue. And the osteoblasts become less active, and the osteoclasts are more active, and thus the bone is eroded and not replaced at the same rate. Okay. So dentures, dental implants, if you can afford them, are even better because it allows the transmission of that chewing force to the bone tissue. Okay. All right. Now let's move over to the temporal mandibular joint. Would this be our classifications for joint types were fibrous, like we saw here, and like we saw with the sutures. Cartilaginous. Do we have cartilage holding these two bones together? We have cartilage. However, is there a gap? Do we have a joint space? If we have a joint space, then it's not a cartilaginous joint. A cartilaginous joint is like we have here between the ribs and the sternum. The cartilage is filling in the gap between the two bones. The cartilage here is covering the surface of the bone, making the movement smooth. It's a synovial joint. Remember the synovial membrane from Betsy's lecture? So in this case, we have a synovial membrane, connective, loose irregular connective tissue that is going to close in that joint, okay? And we have another piece of cartilage, a piece of fibrocartilage, forming a disc, and that would be this structure right here. So you've heard of the menisci of the knee? That's a piece of fibrocartilage in a synovial joint. Okay, it helps to absorb pressure. So there is a fibrocartilage disc within this joint. And look what happens, and this is a note we'll end on. Look what happens when you open your mouth. Because we normally think, like the occipital condyle on the first vertebra, it works like this. It rocks into space, okay? Or the head of the humerus in the glenoid fossa moves in that space. What happens when you open your mouth, instead of just doing this and rocking in that space as you open and close your jaw, it does this. And then it has more room to move. And when you close your jaw, it slides back up in. The whole cartilage and the mandibular condyle move out and then move back in when you close your mouth. So if you look here, here's the fibrocartilage, the mandibular fossa. That's the jaw closed, all right? And then here the jaw is open, and notice how this is no longer up in that space. It's anterior and forward and actually resting on this surface, all right? So someone who has TMJ problems, TMJ for temporal mandibular joint, that surface isn't smooth and it can catch, and the cartilage doesn't move all the way out or it doesn't move all the way back in again. So my younger sister has problems with this, and she used to, maybe she still does, wear an appliance that would keep her mouth closed and not fall open when she slept, and it would catch, and she'd wake up with she would be able to move her, lockjaw would be able to move her mandible. And so when I was in my mid-20s, the dentist said, well, do you have any problems with TMJ? I said, no, see? And I opened my mouth, and for the first time in my life, I heard it click. It's like, oh, well, I guess maybe I do. And now I notice it clicks. I'll hear that kind of snapping. And so it can be a problem with the shape of the bone or the shape of the cartilage or the shape of the condyle as it fits in that position. Okay? So for the information on the TMJ, I want you to know that it is a synovial joint. Meaning it's a space, a joint cavity enclosed by a synovial membrane. Freely movable, immovable, or slightly movable, provided you don't have TMJ problems. Movable. All of our synovial joints are freely movable, all right? And our term for that is diarthrotic. So most of the joints, when you think of a joint, the knee joint, the hip joint, the fingers, those are all synovial diarthrotic joints, all right? So let me just, sorry, I'm going to take a picture.
No, I didn't write down diaphragm.
Oh, diarthrotic, D-I-A-R-T-H-R-O-T-I-C. I'm going to write it down again because I'm going to give you a summary. So we have fibrous joints, all right, where we have a fibrous connective tissue holding the two surfaces together. And we have cartilaginous joints, where we have cartilage holding the two surfaces together. The epiphyseal plate, by the way, is an example of a cartilaginous joint between the epiphysis and the diaphysis. There's no gap there. It's held together. Fibrous joints can be either slightly movable or immovable. So slightly movable is amphiarthrotic, and immovable is synarthrotic. And fibrous joints can be both. So far we've talked about synarthrotic, the sutures, and the teeth. When we get to the extremities, we have a membrane between the two bones in the forearm and the leg, and I can certainly move my radius and ulna, so those are not immovable. All right, but so far the two I've talked about are synarthrotic. Cartilaginous can be either amphiarthrotic or synarthrotic. When you breathe, your ribs move slightly. So that's an example of amphiarthrotic. We'll talk about this tomorrow when we do the thoracic cage. And the epiphyseal plate, we don't want that to move. So we're talking about the epiphysis twisting on the plate. Not a good idea. We're not talking about the actual interstitial growth. We don't want the bone turning like twisting on that epiphyseal plate. So that would be an example of synarthrotic. Right? And then the third type, synovial, is always diarthrotic. So we'll keep reviewing this as we move through the bones and talk about the different joints associated with each of those different components that we talk about. All right, so I promised you a second lab time. So you have the next 30-35 minutes available. There's also open lab today. Those of you that have come to Jeff's sessions, students from other classes, 431, 430 come in, and so you can continue studying the skull. In addition, he's having an extra open lab tomorrow. When we're done with class, I think it starts at 2 or 2:15 as well. We get done at 1:30. Because we have our next exam, we only have 2.5 weeks for this next section. So our next exam is a week from Tuesday. Okay? Yes?
What does that exam stop at? What topic?
It stops with the bones of the foot. Normally I do a joint at the very end, but I'm putting them in as we move through the bones. So it's the bones of the feet. It's all skeletal system.